Welcome back to the OHSU Effect, Inside Health and Science at OHSU. Time to talk about women's health issues, particularly preventing the need for C-sections. I have two experts here with me to talk about this. Dr. Caughey, Director of the OHSU Center for Women's Health, and Carol Howe, Director of the Nurse Midwifery Program. Hi, guys.
Hello.
Good morning.
So according to the CDC, the number of women having C-sections is on the rise. Dr. Caughey, maybe you can tell us what's driving this trend.
Well, you just told me we only have 8 minutes. I give a very brief hour-long talk on what's driving the rise. But to summarize, it's a variety of things. I think it really boils down to culture, that our culture regarding cesarean delivery has been much more permissive over the past decade or so. And this, I think, is driven by the medical legal environment, putting pressure on clinicians to bail out of anything that is slightly abnormal, quote unquote, abnormal in labor. And this then leads to more cesarean deliveries for people with a prior C-section, more cesarean deliveries of people with a breech baby, more cesarean deliveries of people with a slightly longer labor. Those are, I think, are the big drivers. Carol, you want to add to that?
I think that the C-section rate started going up when we introduced electronic fetal monitoring back in the early 70s, and it's been just a steady climb since then. I think all the things that Aaron has cited are exactly right. I would probably add inappropriate induction of labor to the list.
And the only place I'm going to differ with Carol a little bit is that it's true. It rose in the 70s and 80s until 1989. But in this country, we are the only developed country to ever show a decline in C-section. And from 1989 to 1996, in this country, we actually reduced the cesarean delivery rate. And that is what gives me hope that we can do it again.
Well, why is it so important to reduce the rate?
Well, I think that there is increased morbidity, both in the short term and the long term, associated with cesarean section. Obviously, it's major surgery at the time. There's a longer recovery period at a time when you're trying to learn how to parent and bond with your child. But there are also longer-term morbidities associated with it, including the risk of uterine rupture in a subsequent pregnancy, and also the fact that you have a scar on your uterus encourages the placenta to implant in places where it shouldn't implant in subsequent pregnancies. So there's an increased risk of both placenta previa, where the placenta comes in front of the baby, and placenta accreta, where it implants abnormally deep in the uterus.
So is there more risks for the mom or for the baby in a C-section?
Well, that's a great question. And unfortunately, the best way to answer that kind of question would be to do the gold standard of clinical science, which would be do a randomized trial, right? So you take 1,000 women and you flip a coin, and 500 get elective cesarean deliveries and 500 get a trial of vaginal delivery, right? But we don't think that study is ever going to be done. If I was a woman, I wouldn't consent to be in such a study. So we don't think that such a study is going to be done. So we do proxy studies. We compare women who've had a C-section to those that have had a trial of labor or have had a vaginal delivery, and we try to tease that out. Certainly it does seem that a cesarean delivery carries a battery of risks, and Carol just mentioned some of those, to the mother in the current pregnancy. And then the nicest study of this, I think, is by Steve Clark and his group out of Healthcare Associates, which showed actually an increased risk not of just bleeding and infection, but actually of maternal mortality. A woman is more likely to die if she has a C-section than if she has a vaginal delivery. But I think Carol also pointed out that it's not just the current pregnancy, but it's also future pregnancies. And we know that in addition to the placental abnormalities, we see that babies are more likely to experience a stillbirth in subsequent pregnancies after a C-section. There's questions about fertility that haven't been well answered about a prior C-section. So we think that just doing an unindicated surgery for no good reason doesn't make any sense.
OHSU is just one of a handful of hospitals in the country that offers women the chance to deliver their breech baby vaginally. So is that safe?
Again, the words like safe are challenging because what is the threshold? So, I mean, I drove here this morning, and I think that the chances that I would have been hit and injured is probably a little bit higher this morning than for someone having a trial of labor with a breech baby, right? But is it riskless? No, nothing's riskless. And I think that this issue about the trial of labor in the setting of a breech baby goes down to very specific risks. And we know that actually somebody did do a randomized trial of this, And it is true that a trial of labor in the setting of a breech-presenting baby connotes higher risk to the baby, right? And we have an absolute number. We can quote that to people. But doing an elective C-section connotes risk to the mom. And so we think that then it's a question that women should be allowed to answer for themselves what they want to do. And so that's why about a year ago, OHSU brought back the idea of allowing a trial of labor in the setting of a breech baby.
And Carol, can any OBGYN or any midwife do that procedure?
That would depend. Certainly any physician could that was trained to do so. For midwives, it would depend on where they practice. They could in Oregon. Our practice laws are quite broad.
Well, how do you determine whether an expectant mom qualifies? Or is it just like you mentioned, up to her?
No, that's a good question. We think that there's a battery of things that should be done to minimize that risk. Among those include guesstimating the size of the baby, and we would like the size of the baby to be between about 5.5 and about just a little less than 8.5 pounds. We also can do very specific measurements on the size of the woman's pelvic bones, actually, using an MRI or a CT. And the one thing about the big trial that was done, that was a worldwide trial, only 10% of the patients in that trial actually had such estimation of the pelvis. And so we think that with such estimation, we can actually reduce that risk. So we do that. And then we have to have available providers that are willing to perform that service, as Carol mentioned.
Well, there seems to be a number of birthing options for expectant moms to consider these days. I mean, there's at-home births, water births, in-hospital deliveries. Which is safest for mom and baby?
I think they can all be safe for a low-risk mother in the hands of a qualified person to perform the birth. Women with high-risk pregnancies, twins, VBACs, breeches, they need to be in the hospital.
Dr. Caughey?
I would agree. I mean, I generally don't like to say this is safe, this isn't safe to people. I generally talk about these are the things that can happen if we do this thing, and these are the things that can happen if we do the other thing. And they both will have some risks with it. It's tricky because obviously pregnancy and birth are normal physiologic processes. And so you don't want to then over-medicalize and over kind of scare patients or scare women into one arm or the other. And so you have to be kind of dispassionate as possible about these risks. But I think that non-informing is also, it feels wrong in terms of how we care for these women. So it's a challenge to both counsel and give information and then help them make a decision that they feel supported in and that values their preferences.
All right. Thank you both very much for being here. More of the OHSU Effect next on KXL.